Hello, HSC 110. This is Dr. Teresa, and in this video, we're going to be going through relevant information for Chapter 5 on the skeletal system. If you remember, bones were classified as a connective tissue. So what delivers something the ability to be connective tissue is that it will have cells and then some kind of matrix or basement membrane ground substance that's going to be able to anchor the cells into the tissue itself. So we're going to start with a discussion of bones, their composition, the entirety of the functions of the skeletal system, and then we'll go through some of the names and labeling as well. So the functions of the skeletal system, they are support, protection, movement, mineral storage, and blood cell formation. I think that the support function of the skeletal system is probably the easiest for us to identify with. When we talk about support, it gives us the ability to stand upright, to have a form rather than just a blob of tissue. The skeletal system also provides protection for vital organs, like your rib cage goes around your heart and your lungs. So protection around vital organs and systems. Your vertebrae are around your spinal cord. Your skull is around your brain. When we talk about movement, joints are also classified within the skeletal system. So we understand that we have bones that have muscles attached, and then these muscles will help move the body in particular motions and directions and planes. Probably my favorite part of the skeletal system, which we don't often associate with it right away, is the mineral storage category. So mineral storage says this, okay? Your minerals are stored within the matrix of your bones as well as your teeth. So if you remember me talking weeks ago about the body's ability to triage, meaning the most vital functions will happen first, okay? When it needs something, particularly mineral-wise, to maybe, keep your heart beating, it's going to pull minerals from the bones and the teeth in order to do this. And I think that has implications across the board as we see manifestations and diseases and disorders that happen to have, their presence known in the bone. Also, we have blood cells formed within the bone. That's the start of everything. And when I say blood cells, I mean all of them. They all begin in the bone marrow in their bones. So this is, yes, your oxygen carrying capacity, because it will make red blood cells, but it also makes platelets. So we have clotting potential that begins within the bones. And then we have our white blood cells that start within the bone marrow as well. It is such a cool process, and they all start from a stem cell, and then they get told what they want to be when they grow up through, different stimuli in our body that will dictate that. So just a little bit more about the mineral storage portion. Again, I find this super fascinating. We think of bones and we typically think of probably calcium and vitamin D. Yes, those things are part of it, but not all of it. We also have other things and minerals, both positive and negative things that are stored in the bones. For example, phosphorus, which plays a role in the matrix formation of bones and teeth, but also pulled for other chemical reactions elsewhere in the body. Also, lead is stored in bones, so that's relevant. If we come in contact with toxins or heavy metals, they often get stored in our body tissue, and sometimes they're not helpful. There's something within the bones called the medullary cavity. This is a hollow space inside most long bones. And we'll get into the classification of bones shortly. The medullary cavity is also known as the marrow cavity because it will store the bone marrow. And this is a flexible tissue. That's something we call hemopoietic tissue. Hemopoietic tells us that it's responsible for the formation of the components of the blood. Now, when we talk bone marrow, there are two types. There are yellow and red. Both have a rich blood supply, but the yellow is primarily fat. And as we age, we will transform our red marrow into yellow. So if you think about that, if red bone marrow is hemopoietic, meaning it's making all of our blood cells, both red blood cells to carry our oxygen, but also our white blood cells to fight infections. If we have less of the red bone marrow, we lose capacity to produce those things. Just a super side note, in blood cell formation, okay, if the bone marrow is producing a lot of red blood cells, a red blood cell only lives for approximately 120 days. So about 4 months. And then it'll be resolved. All of its components can be recycled. The body is great at recycling too. It uses what it has, and it will have to use its own resources in order to be able to survive, really. Now, when we're looking at the actual composition of a bone, okay, we have different parts. You have different bone cells. You have certain cells that will build bone, certain cells that will break your bone back down and dissolve it and reabsorb it. Those are super neat functions. But generally speaking, one type of cell that we see in our bones is called an osteocyte. This is a mature bone cell. 60 to 70% of a bone's weight will come from its mineral content, which is primarily calcium carbonate and calcium phosphate. Calcium carbonate is chalk, okay? And that probably makes up about 10% of the bones. But these mineral salts, as we call them, they will make deliver the bone its ability to be hard and will resist compression. Now, there's another approximation of between 30 and 40% of bones that is made of a protein named collagen, which we've mentioned previously. Collagen delivers a bone the ability to resist like twisting. Okay, so it actually delivers bone a level of flexibility. If a person has an inability to produce collagen in the bone, they're going to have brittle bones, and that's going to cause a problem for their overall health. The bones of children will tend to be more flexible because they will have this higher collagen content to them, as well as a higher water content. Now, within a bone, we also notice that we have two types of bone tissue. We have cortical bone or compact bone, and trabecular bone or spongy bone. Cortical bone is the cortex of the bone, or the hard outer layer, whereas the trabecular bone has a mineral component to it, but it's more porous. It looks like a sponge. So if you've ever, and you can look in your book on page 122 and get an idea of what spongy bone or trabecular bone looks like. There's a really nice picture there on the bottom. If you've ever seen like an image, radiographic image of somebody with osteoporosis, this is really evident and apparent. How these structures become weakened with such a disease process at play. The cortical portion of the bone, again, that's that outer compact bone portion. This will be stiffer due to a higher mineral content. The trabecular bone can be, deliver some rigidity, but it's lightweight due to like the porous nature of trabecular bone. Most bones will contain both cortical and trabecular. The function of a given bone will determine whether it's composed mostly of cortical or trabecular bone. For example, the long bones in the arms and legs are primarily composed of cortical bone, although they do have trabecular bone, more so in the ends. In all bones, the outer layer is composed of a hard protective cortical bone with the spongy trabecular bone present to varying degrees. So if we want to compare cortical bone to trabecular bone, this is a very nice chart that I have up on the screen, but it's also in your book on page 123. Cortical bone, again, is compact bone, so it's dense. Its mineral content will be higher. That is going to deliver a higher level of strength and resistance to compression. It's not great at absorbing shock, and in comparison to trabecular bone, although it does have a flexible component to it, it's not as flexible as trabecular bone. And again, it's cortical, it's on the cortex. Anywhere in anatomy and physiology that you see a cortex, that's its outer layer. When we talk trabecular bone, again, it's going to be porous. It's going to look like a sponge or a honeycomb. Because there's less of it there due to its porous nature, it will then inherently have less mineral content to it. It's not going to be super strong, but it'll have more flexibility than cortical bone or compact bone, and it will deliver a higher degree of flexibility. And I did mention that it's inside the vertebra. We find it in the femoral neck, the wrist, and the ankle bones. Okay, so when we're looking to classify bones, we classify them starting by their shape. We have long bones, we have flat bones, we have short bones, we have sesamoid bones, and we have irregular bones. So the long bones, we'll find them, that's like your upper arm, your humerus, that's called the humerus. Your thigh bone, that's your femur. These are long bones. Also your radius, your ulna, that's your forearm, and your tibia and fibula, that's the lower part of your leg, distal portion of your leg. So we'll find that in a long bone, it will have a cylindrical shaft. It'll have like knobs on the ends of the bones. Within those knobs, we'll find higher concentrations of trabecular bone wrapped in cortical bone. And the shaft will enclose a medullary cavity. In the short bone category, these are shaped roughly like a cube. and they're composed mainly of trabecular bone. They'll comprise the bones of the wrist and the ankles. When we talk flat bones, they're going to be generally flat, and they'll have a curve to them, highly likely. We're going to see flat bones in the sternum. That's your breastbone where the ribs articulate. And your cranium or your skull is also a flat bone. And again, that's by design. We know that the skull is curved. These bones will tend to protect underlying organs, but also provide or can provide large areas for muscle attachments. The scapula is also included in this category, and the ribs. When we talk about a sesamoid bone, this is an interesting bone. You're going to find a few of these throughout the body. Sesamoid bone, they get formed within a tendon. Tendons are the connective tissue that will anchor a muscle to a bone, whereas a ligament will connect bone to bone to form a joint. The irregular bones, this is kind of like a catch-all category. We put the bones of the spine or your vertebra in there, as well as the sacrum. The sacrum is kind of that triangle bone at the bottom of the spine. This is also categorized in there. Now, when we talk the anatomy, gross anatomy of a bone, okay, they have what we call bony markings. There's a chart on page 125 in your book. I'm going to go through some of the language there, just so you have an idea of when we're identifying a bone. Okay, if you had a bone laying on the table, could you tell me what it is? And could you tell me what the name of the marking is, kind of thinking, okay? If you move on into higher levels of anatomy and physiology, like if you take A&P1, that's something you'll learn to do there. But for our purposes, I'm going to go through it so you have an awareness of some of the language, some of the names. And again, this is, we make identifications of the markings on bones. Now, the point here is that they're actually not random. Okay, all the weird little bumps and grooves and flat spots and all of that, they're there for a reason. So we have certain things we look for when we are looking at the surface of the bone. We're looking for projections, meaning something that sticks out. We also look for depressions. Okay, a depression would be maybe a groove or a flatter spot in a bone. And then we also have names for openings within bones. We also have things that on bones, bony markings, that we're going to see are components of joints or joint articulations. So within the joint articulation, some of the names or words we'll see associated with them would be a facet. An example would be one of the joint articulations within the vertebra or between the vertebra. A condyle is another example. A condyle will be on the articular surface of a bone. When I say articular, okay, that's going to articulate or join to another bone. So we will see condyles typically in areas like this. For example, the femoral condyles. Sometimes we see the head on a bone. This is something that sort of looks like that bulb we were mentioning on the end of a long bone. This would be an example of the head of a bone, like the head of the femur. You also have the head of the humerus. When we get into the category of projections on a bone. There are things called processes, things that stick out. Okay, if it's a projection, it sticks out in some way, shape, or form. Now, to be able to determine if something is, a process rather than a tuberosity takes a little practice and will be dependent on the bone and the size of the projection. We're not getting into that here. I'm just super side noting, explaining the naming, the nomenclature. Okay, so I'm just gonna read through some of these. The trochanter, this is for, like the name for a process on the end of a bone. For example, we have something on the femur. Again, the femur is your thigh bone or your upper leg bone. We have something called a greater trochanter and a lesser trochanter. Sometimes on a bone, we see a projection that we call a crest. A crest is a prominent, narrow, bony ridge. Sometimes we notice a line. This is just a slight elevation and a long, narrow ridge. So it's a little bit different than a crest. We could see a spine on a bone. Okay, something, for example, the spine of the scapula. This is going to be way more prominent than a crest or a line, and something that's really going to project off the bone. We have tubercles and tuberosities. Tubercles are small and rounded things that stick up off of a bone, and a tuberosity is more rough and a higher elevated surface. So it's bigger than a tubercle. We mentioned that we have condyles. Then we also have an epicondyle. An epicondyle, if you look at that prefix, epi, above or around, this tells us that we have something sticking out above or around a condyle. We'll also see in projection something called a neck. We have the femoral neck. We'll see this in other bones as well, but this would be a column that would support the head of the bone. When we get into the depression and opening category, we have depressions that are known as fossas, that are shallow depressions. We have depressions known as sinuses. Sinuses are cavities. They're usually hollow and they're filled with air. And yes, you're likely thinking about your sinus infection, right? You have more than the ones in the front of your head, by the way. You have them in multiple places throughout definitely throughout your head. We may see a depression known as an alveolus. Okay, this would be a small hollow depression. Now, when we get to an opening, we're going to see words like foramen, meatus, and canal. The difference being a foramen is a rounded opening. A meatus is the beginning opening to a canal, and the canal is the tube itself. So, for example, you have in your skull something called the foramen magnum. It's where your spinal cord comes out of your brain and drops down through your skull to make it into your spinal column. An example of a meatus is your external auditory meatus. That is the opening to your ear or the opening to the ear canal within your skull. So we can look at a few examples of different kinds of bones and different bony markings. So here is an example of the femur. The femur, again, is your thigh bone of your leg. It will articulate with your pelvis and articulate at the distal end with the tibia and the patella to make the knee. So we're looking here at the posterior view of a femur. This would make this particular femur the right femur. And we'll know that by looking at the head of the femur, which is actually the ball of a ball and socket joint that it articulates into the pelvis with. Right below that, you can see evidence of the neck, which I mentioned, and it's kind of the bridge, right? You can also see evidence of the greater and lesser trochanters. In between them, there is a crest. Remember that a crest is a prominent, narrow, bony ridge. So this one joins the greater trochanter and the lesser trochanter. Now, I want to point out something here, okay? That these markings on these bones, again, they're not random, okay? And like a lot of the processes are points where we have tendon and or ligamentous attachment. Sometimes where we have depressions or openings, we're going to find that those particular set of bony markings will hold a channel for maybe a blood vessel or nerve. Okay, back to the femur. Also, you notice a marking called the gluteal tuberosity. Again, that tuberosity is a rough and elevated surface. Then we have this ridge. This would be a line. Okay, this one in particular is called the linea aspera. This is a slightly elevated, long and narrow ridge. If we look at the more distal end of this femur, again, we're looking at it from the posterior view. This would be someone's right upper thigh bone. On the medial aspect, some things that we'll notice, something called an adductor tubercle. The tubercle, again, is a small rounded process. Then we have what's called a medial epicondyle. If we have an epicondyle, chances are we have a condyle because the prefix epi will tell us that it's above or around the condyle. Lo and behold, we do have a medial condyle. Then you'll notice like a groove or a space or a depression that is called the intercondylar fossa. Lateral to that fossa, we will have the lateral condyle and lateral epicondyle of the femur. And there are more markings, but these are some general ones that we will notice. In our next slide, we see a picture of the scapula. The scapula is your shoulder blade. So we are also looking at this from the posterior view. Okay, in this slide, this is someone's right shoulder or right shoulder blade. So some markings we're going to see on the scapula. Here we have something called a supraspinous fossa. Let's look at the words. First of all, a fossa tells us it's a depression. Supraspinous, supra, above. Or you could say bigger than, but I would say above, okay, above the spine, because we also have then delineated here. Here is the spine of the scapula. If you recall, a spine is a sharp, slender process. So it's this projection here that will run pretty much the width of the entire scapula. Then below the spine or under it, we have the infraspinous fossa, infra telling us that it's below the spine. If this is our right scapula and we're looking at someone's back, okay, the acromion is a process that's going to project laterally. And this is actually like over here is where your arm bone will articulate over on the right side of this slide. Okay, now if we're looking at the skull, some examples of some markings here. Well, notice here is your external auditory meatus. Again, that's an opening for a canal. We have a foramen here. We mentioned foramens are rounded openings. The socket that's going to hold the tooth is an alveolus. Up on the maxilla, we have a foramen underneath the, it hangs out underneath the orbit. Now here are examples of sinuses, okay? They are hollowed cavities within a bone. And then we have internally in the skull, we can see evidence of a crest. Again, as a crest is a prominent narrow bony ridge. Now, if we're looking at a vertebra, these are meat bones. Again, we would classify them as irregular bones. In this slide, we're looking at a thoracic vertebra from the side. So a few markings that we want to note. It looks like it kind of has a tail in this picture. Okay, so this tail over here on the right side of the slide, this is the spinous process. If you're looking at someone's back and you can kind of see the bumps that run down their back, this is really what you're seeing, the spinous process of all the vertebrae lined up in a row. The transverse costal facet, this is an area or depression where we would have a rib join the thoracic vertebra. From this view, you can kind of see the transverse process. If we were looking at a different view of this guy, like a transverse section, it would be easier to see. Also, we see what's called an inferior articular facet. The facet, again, is a small, smooth articular surface. We're also going to have a superior articular facet. So inferior and superior, that's going to tell us where we're at on the bone itself. Articular tells us it's articulating with something else. And then again, the facet delivers us evidence that it's a different kind of surface. On the body of the vertebra, which is the biggest portion, this chunk here on the anterior portion of the vertebra, we have something called a superior costal facet and an inferior costal facet. So this again is going to be another place where a rib is going to touch this bone. Okay, so if we're talking more in depth about the structure of a long bone, the long bone has certain parts. It will have a diaphysis, a periosteum, and an epiphysis. So let's walk through some of that. The diaphysis of the long bone is the hollow shaft composed primarily of cortical bone. The periosteum is a fibrous connective tissue membrane that wraps around the diaphysis. And in that periosteum, it has little fibers composed of collagen. These guys are known as Sharpie's fibers. And you can kind of see them here on this picture. The Sharpie's fibers help anchor the periosteum into the cortical layer of the bone. The periosteum will also carry blood and lymph and nerves. It does play a role in bone growth and repair and nutrition supply to and from the bone. Again, the hollow center that we get to see here within this long bone is the medullary canal. We mentioned the yellow bone marrow. Here's evidence of that. Okay, so this canal will begin to fill with yellow bone marrow by the time we're 5. It does have a rich supply of blood vessels, and it will help store fat. The medullary cavity is lined with a layer called the endosteum. The bulbous ends of the long bones, okay, here and here, these are the epiphysis. These regions are primarily composed of trabecular tissue that will contain the red marrow. Remember, the red bone marrow is hemopoietic tissue responsible for the production of red blood cells, or the whole stem cell line for blood making. Although all bone marrow is red at birth, only about half of the marrow is red by adulthood and the other half is yellow. When we talk about the epiphysis, this is also the site of bone growth in a long bone. And it will continue to enlarge as the person ages, adding to the length of the bone. Each epiphysis will be surrounded by a covering of articular cartilage. So here on this picture, at the distal end, this is a humerus, by the way. Okay, this is distal end, which would be your elbow, part of your elbow bone, where it will articulate with the radius and the ulna. We notice this white covering. This is the articular cartilage. Within this bone, and you can kind of see it here, okay, kind of. We have a better picture. We do. This is a great picture of the cortical layer of bone, as well as the trabecular or spongy bone on the innermost portion. Remember that the outer covering of the bone, that's called the periosteum. The sharpies fibers are these little fibers that will anchor it into a cortical layer or compact bone. So we notice within this compact bone, it definitely has a different microscopic structure than the spongy bone. These shapes within the cortical bone, they look like tree rings. Okay, these units are called osteons, and they have what's called a Haversian canal or Haversian system. In the center of this system is the canal. Okay, within this canal, we're going to house the blood supply to and from bone. If we magnify one of these osteon, one of these rings of the tree or Haversian systems, we can see some other structures. The rings themselves are called lamellae. We have two different kinds of lamellae. They can be concentric, which would be the ones we're seeing that goes around that Haversian canal. And then there's a circumferential lamellae, which would be this guy here, kind of goes around the whole entire layer, layer of cortical bone on the outside. Packaged within or in between the lamellae are those osteocytes. Again, remember, osteocytes are bone cells. Osteo should give us the clue that it has to do with bone. Cyte should give us a clue that it has to do with cells. These osteocytes are kind of sandwiched in between the layers of the cortical tissue. These osteocytes are housed in little pockets called lacunae. This isn't the only place that we will see lacunae, but definitely within this type of tissue. We also, within the layers of the lamella, we have these little thread-like things, or little like connecting wires or threads that run through the lamellae. They're called canaliculi. Now, throughout these osteon, okay, again, the osteon is called the Haversian system. Within the center, which the system is a series of the lamellae or rings, concentric lamellae, with the Haversian canal running through the center of the osteon. We're in the center of all of these rings. That Haversian canal, again, houses the blood supply. Now we have little connecting canals called Volkmann's canals, or perforating canals that will connect each osteon. And you can see that way better in this other picture here. So here's our osteon. In the center is the Haversian canal, which is housing blood supply. And then linking multiple osteons, we have that perforating or Volkmann's canal. Okay, so we're going to talk about how a bone actually grows. We're going to talk about the role of different kinds of cells, the osteoblast and class, and then we'll be able to describe how a bone grows and sort of what will drive the growth or the breakdown. So when we're talking how we're building bone, there are, remember we mentioned osteocytes, those are mature bone cells and they have a particular function. When we're talking bone growth or even bone dissolution, okay, breaking down of bone, we have to mention other cell types. There are osteoblasts, B for boy, blast for, or B for build. Osteoblasts will build new bone. Osteoclasts with a C, like in cats, these will eliminate weak or damaged bone tissue, or if we need to access or harvest any of the minerals within the bone, the osteoclast will become active. What we have to understand, which is why this is a cool tissue type, is that bone remodeling is constantly taking place. So we have to understand that bone growth will involve both osteoblastic activity and osteoclastic activity. However, both osteoblasts and clasts will remain busy over the course of a person's life. In a healthy adult bone, the osteoblasts and clasts will be balanced. As a result of the balance, the bones stay strong and they can do their varying functions. So how this works is in fetal development, bone modeling is the process in which new bone is created through osteoblast activity during the formation and the growth of an immature bone. The way that this process begins is in fetal development, it will start out as hyaline cartilage. That is going to be relevant the whole way through. Although we see hyaline cartilage in different parts of the adult body, when this same material is within the fetus, we see a very quick replacement of this cartilaginous model into bone. So then ossification is the actual process of the bone formation that will begin within early fetal development. And it occurs in two phases. It has a bone matrix shell that will cover the hyaline cartilage through the activity of the blast. And next, the osteoclast will reabsorb the enclosed hyaline cartilage and create a medullary cavity within the bony superstructure. This becomes relevant as we see bones develop then within childhood. So when we are in our childhood years, the bones will have a tendency to grow a lot in length. And that is one value, purpose, and function of the growth plate. We hear probably a lot about growth plates. This is also known as the epiphyseal plate. This is located close to the ends of the long bones, where osteoblasts on the central side of this plate will produce new bone cells, which then can be translated into bone length growth. At the end of the growth period, or soon after adolescence, the plate will totally calcify and dissolve, and the plate will fuse. Most epiphyses will close around age 18, but we still may see some into our mid-20s. So this epiphyseal plate that's present during the growing years, when it completely fuses the ends of the bones between the diaphysis and the epiphysis, the name changes from the growth plate or the epiphyseal plate to the epiphyseal line. So then in adult bone growth, we even though we're adults, we're still doing this bone remodeling constantly. And for the reasons that I mentioned previously, for mineral matrix building and utilization. In adulthood, the osteoblasts, again, B for building cells, in the internal layer of the periosteum will build concentric layers of new bone on top of the existing ones. To understand this process, it helps to visualize the way in which the rings on a cross-cut tree stump will reveal the tree's growth. While the osteoblasts are building new layers, the osteoclasts will resorb layers of bone inside the medullary cavity, causing the diameter of the cavity to be progressively enlarged. This beautifully engineered process occurs in such a way that a healthy bone remains optimally functional, lightweight, and strong enough to resist daily stresses. As people age, there's a progressive loss of collagen and elasticity, and thereby an increase in that bone brittleness. So bone mineral normally will peak in women at about 25 to 28 years of age, and in men about 30 to 35 years. Thereafter, the bone mass is progressively lost, and those age ranges are variable. That's written different in different texts, and it is about hormones. Okay, if I haven't taught you this yet, any time we see something in physiology that notes a difference between the predisposition of a disease manifestation between male and female, I mean, besides anatomy, what's the difference? It's hormones. Okay, so hormones would be the contributing factor, either presence or lack of testosterone and or estrogen, if that makes sense to you. So those hormones drive a lot of things. When we talk bone remodeling, it's always changing. Again, I've said that multiple times, but it is at that microscopic level, doing the building and the breaking down continually. Again, using osteoblasts, B for building, and osteoclasts to do the whole remodel process. Now, this is relevant for broken bones. This is relevant for our understanding of even like braces and retainers. That bone remodeling process that's continually happening is the foundation of those kind of therapies, because forces such as gravity, muscles, forces sustained when people push or pull on something, this has an impact on bone growth. And this is relevant, and I'll talk about it in a second. The remodeling process converts the size and direction of the forces acting on the bone and changes it into mineral density. So what's happening here is when there is, we'll call it stress on a bone in the form of usually pressure, the body will respond to that pressure or stress by throwing down more bone material to be able to handle the compressive force. Okay, so let's put that into context of life. If you have an injury, if you have a repetitive activity that you do, okay, years and years and years of something, right? If you're swinging a hammer for a long time. If you have some type of musculoskeletal, quote unquote, stress, maybe you, from swinging the hammer for 15 years, you bulked your deltoid muscle on your right arm, okay, and your right shoulder. And that's going to have an impact on that weight. That muscle mass is going to have an impact on the bones in the area. Therefore, you can impact bone growth by building muscle. This is also relevant when we see osteoporotic conditions. One of the recommendations and treatments is to get a person doing weight training. And it's just physics. If you add mass, the body has to respond by being able to do something with that mass. Now, when we're talking about hormonal influence on how all this works, the actual calcium in the blood will have an impact on this whole bone remodeling system as well. If blood calcium levels are too low, your parathyroid glands, which are on the back side of your thyroid, they're going to release parathyroid hormone, and that is going to activate an osteoclast to resorb bone matrix and release calcium into the bloodstream. If calcium in the blood is elevated, calcium then be pulled out of the blood and deposited into the matrix by another hormone called calcitonin. And this comes from special cells in the thyroid gland. So these two are paramount in the regulation. Now, vitamin D is also part of this. Vitamin D, you have a particular form of it in your skin when sunlight hits at a particular frequency of light, hits this, it's called a pre-hormone, by the way, vitamin D is. It will convert it into something more usable in the body to help with the regulation of calcium in the blood. So this is an amazing homeostatic mechanism. So as we're talking about this bone remodeling, the terms hypertrophy and atrophy come up. So hypertrophy, okay, there's hyper, that prefix should lead us to understand that something's big or beyond or above. So when bone is subjected to stronger forces, it will hypertrophy. Okay, again, this is the principle of directing someone with osteopenia or osteoporosis to do maybe some low-level weight training to try to add some mass, stress the bone a little bit, have these hormone systems activated better. Now, atrophy would be the opposing force. people who are subject to reduced forces are prone to bone atrophy or loss of bone mineral density and strength. So if someone's in bed for a long time and they're unable to do this, this might happen. Can you recover from it? Sure. Delivered the appropriate resources, I think the body can do amazing things, but we have to deliver it time. In this picture here on our PowerPoint, it's not a bad picture, just to get an understanding again of the layers if the previous pictures didn't help you. So here we have in the very center, okay, we're looking at a transverse section of a bone, okay, of a long bone. In the center, this is our medullary cavity. It's lined with this red tissue here. This would be connective tissue. It's called endosteum. Okay, it's not a cartilaginous tissue, but it is in the connective tissue category. Within that lining of that medullary cavity, this is where our osteoclasts will hang out. Remember, clasts with a C. They're gonna dissolve bone minerals and release them into the bloodstream if that's what's called for. Outside of that endosteum, we see the trabecular or spongy bone. Then outside of that, we have our cortical bone layer. Within the cortical bone layer, we do have osteoblastic beef for building activity to lay down more bone. And we have the periosteum that lines the cortical bone. Okay, now we're going to get into some different parts of the skeletal system and do some bone naming and identification. In your book, we are on page 132. So we're going to look at, again, different names of the skeleton, and we'll go through some parts of the cranium. Okay, first of all, when we're talking the skeleton or the skeletal system, we have to recognize it's broken down into two parts to start: the axial skeleton and the appendicular skeleton. The axial skeleton, you'll notice here on our slide, as well as on page 133, is the pink part. Okay, that's kind of the core of your skeleton. It's your head, neck, and thorax, pretty much, okay, and your spine. So we have the cranium, we have the entire spinal column through the bone called the sacrum and the coccyx, and then your rib cage and your sternum. So everything in there, that's axial skeleton. Everything that is shoulders to fingers, pelvis to toes, that's appendicular skeleton. So let's talk about the skull. Within the skull, there are 22 bones, and these bones of your skull are divided into two different groups. We have cranial bones and facial bones. The thin curved bones of the cranium surround the brain. The round shape is structurally strong. It resists impact to forces and tends to absorb less force. The facial bones will protect the front of our head and give the face its individual shape. Most bones within the skull are joined by interlocking immovable joints that we call sutures. Now, let me clarify. They're classified as immovable, and that's partially accurate, okay? Especially when we're younger, they are still able to expand and contract, and they have to be able to do that in case you have, so that your cerebrospinal fluid sort of has an ability also to flow and expand and contract. Now, as we age, it's another aging thing. The cartilage that is actually linking these joints together will eventually fuse, and then they will become immovable, but that's as we become later ages. Now, we have, when we're talking these bones of the skull and face, the jaw would be the exception, the temporomandibular joint. It does allow, or we would like it to, quite a bit of movement. The skull of an infant is quite different from that of an adult due to the level of hyaline cartilage and the fontanelles, or where we don't have the joining of the bones yet because the bones haven't grown up. Compared to adults, a baby's head is a lot bigger than the rest of their body. The adult skull will account for about 1/8 of the total body weight, where the skull of the newborn represents about 1/4. As previously talked about, the skeletal system of a child will include regions of hyaline cartilage. In an infant, the sutures of the skull are composed of a soft connective tissue, which will eventually ossify. And we recognize this as when a baby's born, it's going to have soft spots. Okay. The soft spots are the fontanelles. The sutured joint, or these fontanelles, they serve the function of allowing compression of the skull through the birth canal. Okay. When we're talking the cranium itself includes 8 bones. There are 2 sets that are paired, left and right. And then the rest are single bones. So within the cranium, we have the frontal bone. We have 2 parietal bones. We have 2 paired temporal bones. We have 1 occipital bone, that's the base of your skull. We have something called an ethmoid bone. This makes up the large portion of what's called the nasal septum. The ethmoid bone has something on it called the crista galli, and we'll see a picture of that shortly, which is a superior projection that holds an attachment to the brain, actually. This ethmoid bone is surrounded by something called a cribriform plate, which is a porous region around the crista galli. And the holes in it allow your olfactory nerves to pass through. Then we have a bone within the cranium called the sphenoid bone. This is a butterfly-shaped bone, and it's located on the inside of the skull, and we're going to be able to identify that shortly. The sphenoid bone helps hold the base of the brain, the pituitary gland, and will help form the orbits of the eyes. There's a part of it called the sella turcica, which is what will hold or support that pituitary gland. There is something called a foramen ovale, which is a large opening in the sella turcica. This is an opening for the trigeminal nerve. Okay, let's see if we can look at some bone pictures. Okay, from the lateral view, we get an idea of the location of some of these bones. I'm going to go through the names again. Cranial bones. I'm going to do it rather quickly, but the pictures are on page 134 and 135. Okay. The frontal bone. I hope that makes sense. That's making up your forehead. We have evidence here. You can see this on this picture, and you'll see it on all of the pictures. Also the parietal bones. Remember, this was a pair. The blue bones here on the side. This is your temporal bone on your temples. You'll notice the names will correspond often to things you already know or the name of muscles. The occiput or the occipital bone is the base of the skull. We didn't mention the zygomatic bone, but it is your cheekbone, okay, that surrounds your eye, or at least part of your cheekbone. Here is one view of the sphenoid bone. Again, that's that butterfly-shaped bone. We're going to get a better picture of it from the internal view of the cranium. We also have a nasal bone. That's your nose bone. We have a lacrimal bone, sort of on the medial side of your orbit. And here is a little view of the ethmoid bone. Again, when we get into the internal view of the cranium, we'll be able to see that a lot better. Now, the bone that holds your upper teeth, and it's below your nose, that is the maxilla. The alveolar processes, these are the sort of the ridges that will be around your teeth, housing the alveola or the sockets for your teeth. The mandible is the movable part of your jaw. Right here is your TMJ or your temporomandibular joint, where you have the mandible articulate with the temple bone. Here is an example of, on this slide, we're getting a visual of your sinuses. Okay, again, we mentioned that previously. You have multiple sinuses, and also on this picture, they didn't put this in here, but you have sinuses called mastoid sinuses that are right behind your ear. So if you have fluid in your ear or inner ear infections, the mastoid sinus can become inflamed or irritated and enlarged and cause problems as well. But on here, you can see multiple different sinus cavities throughout the bone. Within the temporal bones, let's touch on that a second, okay? And we're going to flip back to the previous pictures to look at these. We have the zygomatic bone, but off of the temporal bone itself, we have a process or a ridge of bone that sticks up off of it. That ridge of bone is called the zygomatic process. It is part of your cheekbone, but comes off of the temporal bone. Let's look at that for 1 second so I can show you. It's right here. This blue patch of bone here is your temporal bone. Off of your temporal bones comes the zygomatic process. Also, you notice the external auditory meatus, or the opening to your ear canal, is there. Also, off the temporal bone, we have this little pointy process. It is called the styloid process. Now, this is not the only place in your body you have a bone marking called the styloid process, but in this case, it's here. The mastoid process, this is right behind your ear that you'll be able to feel this, and you can palpate that. Okay, touch your own ear back there, right behind your ear, you'll be able to see that. Also within, let's go back up here to this slide. The jugular foramen, the internal acoustic meatus. Okay, we talked about the external acoustic or auditory meatus. You're also going to have an internal acoustic meatus and a carotid canal. The jugular foramen, this is a passageway for the jugular vein, hence the name. The internal acoustic meatus, this is an opening for nerves, for the facial and vestibular cochlear nerves. The carotid canal will be a tunnel through which the internal carotid artery will pass. Okay, facial bones. When we're talking facial bones, we have two fused maxillary bones. The maxillary bones are what forms your upper jaw and holds that upper set of teeth. You're also going to have two palatine bones. The palatine bones form the roof of your mouth. Also, they will include those paranasal sinuses. We have two zygomatic bones or cheekbones. Okay, this is again different from that zygomatic process that came off the temporal bone that we just pointed out. You have two lacrimal bones. These will be within the orbit surrounding the tear ducts. You have two nasal bones that will form the bridge of the bone, or I'm sorry, the bridge of your nose. And I've seen this classified differently as one, but we'll go with what they have in the book here. We have a vomer. The vomer is a bone that makes up a large portion of the nasal septum. Okay, you've heard of people with deviated septums. That's what we're talking about. The two inferior conchae form the sides of the nasal cavity. The mandible or lower jawbone, it's our largest facial bone and the only movable one. The hyoid bone, this one's interesting. This is actually located in the middle of your neck. This is your Adam's apple, okay? And it's right near your thyroid gland. It's linked by ligaments to that styloid process of the temporal bones and also forms a base for the tongue to move. And will move when we swallow. Okay, now let's move to the vertebral column and walk through some of the concepts in there. The vertebral column, or the spine. Let's point out some things. First of all, you have different regions to the spine. You have the cervical region, which makes up your neck, your thoracic region, which makes up your thorax, and your lumbar region, which is your lower back. Below that, we have the sacrum and the coccyx. Now, when we look at the spine from a sagittal view like we're doing right now, we notice there are curves in it, and there should be. The cervical spine and the lumbar spine should have what we call a lordotic curve, okay, meaning that the concavity is posterior. When we look at the thoracic spine, that portion of the spine should have a curve in it, and we call that a kyphosis, where the convexity of that curve is facing posteriorly. Now, you can have exaggerations in these curves, which can cause problems. A couple things that we want to point out within each section, within the cervical region, we have 7 vertebrae. The first and second vertebra of the cervical spine are special, and they're called the atlas and the axis. The atlas is your first cervical vertebra, or vertebra C for cervical 1. The axis is named C2, cervical vertebra number 2. And again, you have 7 and they will be numbered accordingly. So some of the properties of the bones of the cervical spine that we want to look at. The atlas, okay, you've heard, I think it's Greek mythology. I might be wrong there with the mythology that it comes from, but the god or man that held the world on his shoulders, that's what this vertebra is named for, because it's the one that's going to articulate with the base of the skull. With the occipital bone of the skull, it will articulate with condyles. So some parts of a cervical vertebra that we want to note, we'll note that these little projections or processes that stick to the side, these are called transverse processes, okay? You will notice that there are holes. These are called transverse foramen. The cervical spine, all the vertebrae in there will have these features to them. Okay, so if you were looking at them, you would know it was a cervical vertebra by those features. Now the atlas, again, being special that it is, has a couple different markings on it. It will have this large superior articular facet. Again, that's going to be the surface that will join or articulate with the occipital bone of the skull. The atlas also has what's called an anterior tubercle right here, this little bump, and a posterior tubercle. It also has, and you don't find this in the other cervical vertebra, what's called a posterior arch, and it's this curved posterior portion of the bone. When we look at the axis, or C2, we can see what's called the odontoid process, or the dens of the axis. Now, what happens is C1 will sit on top of C2. The fact that this little process will stick up, it will stick up through C1. They'll be connected through some ligaments, but it will give us the ability to rotate our head. That's where a large portion of your rotation comes from, in your head and neck. So in this cervical vertebra, right under the dens, we have a portion of this bone called the body. Okay, we will notice the body in the other segments of the spine as well. Again, we have a superior articular facet. This facet will be able to articulate with a point on your C1 vertebra. At the very posterior aspect, we have something called a spinous process. The spinous process, again, we'll stick it backwards. Okay, that's what we see on someone's back, all the little bumps that are in a row. We have a couple other markings. There is a bridge of bone, okay, that goes between the spinous process of a vertebra and the transverse process of a vertebra, which will be right here on the dens. This bridge of bone is called a pedicle. Now we also have, and it's not marked on here, but we might see it again in some of the other vertebrae, so I'll point it out. We have a bridge of bone between the transverse process and the body of a vertebra. That bridge of bone, in that case, is called the lamina. When we get to the thoracic spine, okay, they have some neat features in there. The thoracic spine has 12 vertebrae in it. And the interesting thing here is that the thoracic vertebra will articulate with your ribs. That's your thorax. When we get to the lumbar region, we will have 5 lumbar vertebrae. Below the lumbar spine, that's what when we're talking about a low back, that's the low back, Okay, but the sacrum is this bone that articulates with your fifth lumbar vertebra or your L5. Okay, so L5 would sit right on here, right on this sacral, what we call sacral promontory. Okay. The sacrum is actually fused bones. Okay, it does have holes in it. The holes are foramina. They're either anterior or posterior sacral foramina, and they will be the exit and or entrance point of nerves and vascularity. Now below the sacrum, we have this, there's a joint right here. The sacrum will join with the coccyx, which is also a grouping of fused bony segments. If someone has broken their tailbone, they have broken their coccyx. That's what's happened. On this picture, you get a good idea of what we're looking at here. You can look at the anterior view of the sacrum. That would be like looking through someone's belly or lower abdomen with x-ray vision. That's what you're looking at. Okay, this would sit right through there. The posterior view, again, L5 or your fifth lumbar vertebra sitting on top. Now, these articular surfaces that are on the lateral portion of this bone, these will articulate with your pelvis on either side. Now, this will create, when that joint happens, the SI joint, sacroiliac joint, okay, that's where we're talking about when we talk about that. And you've probably heard that you have an SI joint dysfunction or something. Many of you may have heard that. That's what we're talking about. From the posterior view, we see this like ridge, kind of looks like dinosaur bones, if you ask me. Okay, it's called the median sacral crest. Again, I mentioned the foramina on the when we're looking at it from the posterior view. These holes will be called the posterior sacral foramina. Okay, this is the picture I was waiting to look at. Okay, so I mentioned some of the structures on the cervical vertebra, and I just mentioned a couple of the structures or characteristics of the thoracic and lumbar spine. Now, the thoracic and lumbar vertebra are going to have a tendency to look like this. So some features of these bones. The vertebra will have what's called a vertebral body. That's going to be this biggest part of the bone here. It's largest, it's thickest. Remember, we talked about that trabecular bone being a primary composer of this bone, and this is where we're talking about. So these guys are fairly lightweight due to how they're comprised or composed. Here we have, let's look at this bottom picture. Okay, we're looking at it from an inferior view. We're looking up at a vertebra. Okay, here's our body. I mentioned the pedicle. Here's that bridge of bone between the body of the vertebra and what's called the transverse process. We have articulating facets. We're looking up at a bone. We're going to pretend that's this guy's sitting right on our head. Okay, now if that happens, we're able to see these articulating facets that are going to come down and land on us. Okay, so this is on the inferior portion of the bone above us. That's why it's named that. Here is our spinous process. Again, that's the bone that sticks out of the back. And the lamina, which I mentioned, is this bridge of bone right here. Between, the lamina is the bridge of bone between the transverse process of a vertebra and the spinous process. Why that's relevant, okay? Do you see this hole here in the center? This is called the vertebral foramen. This is what will house your spinal cord. Now, why I've mentioned that lamina 2 times is because you may have heard of someone having a laminectomy. When they have a laminectomy, they're going to have this piece of bone removed in hopes to alleviate pressure on the cord. Not one of the most successful surgeries I've seen them. In fact, not a good one, usually. Okay, I already mentioned the alternating curves in the spine in relation to the cervical spine and the lumbar spine being what we call a lordotic curve, and then the thoracic curvature being what we call a kyphotic curve. Now, when we're looking at the spine from a sagittal view or someone from the side, we want to see those curves. Again, we don't want them exaggerated, but we do want a curve there. That's going to help with flexibility of the spine and helping it to incur forces. Now, when you look at someone straight ahead, either from the back or the front, that is when we want to see a spine with no curve. So if you have a scoliosis, that's relative to the view someone's taking of you. So scoliosis would be identified by looking at you from the back, from a posterior perspective, or if they get an x-ray from the front or something like that. Here's a great slide for examples of what I just went through. Okay. Again, here's an example of an exaggerated lumbar curve or a lordotic curve. Now, we would see this maybe in someone with a larger abdomen, or maybe be a pregnant woman. Okay, that's a great example of that. Someone with an exaggerated thoracic kyphosis. This is an example. We see elderly women with a dowager's hump due to osteoporosis and maybe some compression fractures and such, and that's a case of that. When we look at someone, again, from the back, this would be evidence of a scoliosis. And FYI, scoliosis does not necessarily equate to pain. People with high levels of scoliotic curves can function with almost no pain at all. So that's not always the reason. There's pain. I honestly feel at this point that scoliosis is there due to other factors within organs and organ systems, or maybe derangement for other and or various reasons. Okay, so let's talk about the intervertebral discs, because I think that discs also get a whole lot of airtime, right? If you blow a disc, have a bulging disc or a herniated disc, all different language and not necessarily the cause of your spinal pain. Okay, the intervertebral disc, or the IVD, this is comprised of fibrocartilage. We learned that in our tissue section. This will provide cushioning between all of the articulating vertebral bodies that are not fused. This will help shock absorb. It does deliver a little bit of movement, but not an exaggerated amount of movement in comparison to other kind of joints and their composition. In the normal adult, the disc will account for approximately 1/4 of the height of the spine. When a person is lying in bed during overnight sleep, the disc will actually absorb water and expand. During periods of upright standing and sitting, when the spine is under compression from weight and gravity a lot differently, okay, positionally, that fluid can be compressed out, and that can be the reason why we lose height. As we age, we say we lose height, and one reason is due to the dehydration of the disc, and this can be for a million reasons. Because a disc, this is really important, I think, receives no blood supply, they have to rely on changes in body position in order to be able to move fluid and nutrients to the tissue, which is why they're really hard to heal. So actually, if we injure one, therapy will include movement because you have to, okay? But it has to be smart movement. Okay, when we get into the thoracic cage, let's talk through a few bones, okay? We talked briefly about the sternum as we were talking about flat bones. Well, there are a few parts to the sternum. You have the manubrium, which is the absolute top part of the sternum. And then you have the body. And then the little tip is called the xiphoid process. Now, anyone that has ever had CPR has likely been warned about the xiphoid process. You don't want to do CPR over top this guy, or we can chip it off and break it and then cause more problems. At the very top in the manubrium, we have this little notch, and you can probably see it on yourself if you look in the mirror at the bottom of your throat. Okay, it's the jugular notch, which will contact again, or I'm sorry, not contact, but be at the top of that manubrium. Where the manubrium joins the body is called the sternal angle, right in this area. The joint between the body of the sternum and the xiphoid process is called the xiphosternal joint. We have the clavicle, or your collarbones, connecting to the manubrium. Now you'll also notice within the rib cage, all the ribs will have cartilage that's connecting them to the sternum, wherever it connects to. This is costal cartilage. You have 12 ribs, you likely know that. Interestingly, you have 12 vertebrae. But there are different kinds of ribs. We're going to go through the classification. Ribs 1 through 7 are classified as true ribs, and that has to do with how they connect to the sternum. They have a direct linkage, or fairly direct linkage, to the sternum. Then you have ribs 8 through 12. Now I have seen this classified differently in different texts. Okay, we're going to classify ribs 8 through 12 as what we call false ribs, due to how they have to all link into the same piece of costal cartilage in order to connect to the sternum. The last two ribs in the false rib category are called floating ribs, ribs 11 and 12, because they connect to nothing. Okay, next we're going to go into the appendicular skeleton. Remember that appendicular skeleton is shoulders to fingers and pelvis to toes. This will be on page 143 in your textbook. So the upper extremity is the shoulder complex, arms, wrists, and hands. Lower extremity is the pelvic girdle, the legs, the ankles, and the feet. Altogether, there are approximately 126 bones within the appendicular skeleton. And the appendicular skeleton is built for movement, whereas the axial skeleton's primary function is more for protection and support. So the upper extremity is well designed for all kinds of tasks. As we know, the muscles, bones, and joints enable us to move from large scale movements to finite movements. So let's go into the shoulder complex and the shoulder girdle. The bones surrounding the shoulder are referred to as the shoulder girdle or the pectoral girdle. This structure includes left and right clavicles, left and right scapulas. These bones serve as the site of attachment for muscles, and it enables us to move our arms very easily. So let's walk through some of the structures of this shoulder girdle. Let's look at it from the anterior. I think the view's better, except when we want to look at that scapula a little differently. Okay, shoulder girdle again includes the clavicles, on both sides. They again, clavicles will articulate within the manubrium of the sternum. But the clavicle on the more lateral end of this guy will articulate with what's called the acromion process of the shoulder blade. We see something called a coracoid process that's also on the shoulder blade. That's going to be, again, we're looking at this from the anterior portion. The head of the humerus, this is the ball of the ball and socket joint of your shoulder, where your humeral head articulates with the glenoid cavity of the scapula. The humerus is your upper arm bone. If you look at the shoulder girdle from the posterior view, and see how it lines up with your spine. We get to see the clavicle from the posterior view. From the posterior view, okay, the scapula, we saw this on a previous picture, but we get to see the spine of the scapula. That acromion process, if we're looking at someone from the back, is going to be more lateral. It's going to be out by our arm, not by our spine. The head of that humerus, again, will articulate into the scapula. This is, again, our upper arm. Remember, we just noticed on our previous picture of the scapula, a few of the markings. Above that spine of the scap, we have what's called the supraspinous fossa, and that's going to be an attachment point of a muscle of the rotator cuff for movement, actually. And you can kind of see how it lines up on the ribs, right? So we're at it will overlap that rib number 7, kind of touch down onto rib 8. So if you go to that inferior angle of your scapula, which is the point of the bone or the blade, you come straight over, you're going to be at about, depending on your position, by the way, at about T6 or T7. Depending on if you're sitting or lying down. Okay, and then that superior angle, if you go straight across, you're going to be right at about the tip, again, depending on your position and if you have any musculoskeletal aberrations. Ideally, it will come right across to the tip of the spinous process of your T1 vertebra, or your thoracic vertebra number 1. Okay, here's a way better view of that scapula. Now, I already mentioned a bunch of things. Okay, acromion we mentioned. Coracoid process we mentioned, and this is an anterior view. Glenoid cavity. Okay, that glenoid cavity, you can see it's lined with articular cartilage. That's where the head of that humerus is going to come in. We have borders and angles on the scapula. I already mentioned a couple of the angles. Okay, we have the lateral border, the medial border, and the superior border. Up here we have the suprascapular notch, just to name a few things. Okay, from this anterior view. Now, I want you to kind of picture this in your head. The rib cage of someone, if you're looking at a person from the front, their front, okay, the rib cage would overlay this, and you would have to have kind of x-ray vision to see this portion of their scapula. Okay, because this is going to be like sliding up against their ribs. When you look at the posterior view, let's look at the angles. I mentioned the inferior angle, I mentioned the superior angle, and then over here we have a lateral angle, kind of takes care of all of this part. I mentioned the supraspinous fossa, which lies on top of the spine of the scapula, and then we have the infraspinous fossa as well. When we're talking the arm, we have the humerus. Within the humerus, we have a couple parts we need to talk about. On the humerus, if we're looking at it from the front side, again, The head of the humerus will articulate with the scapula to form the shoulder joint, the ball and socket joint of the shoulder. We have a bone marking here called a greater tubercle that's sticking out. And then if we have a greater one, chances are we have a lesser one. So then we have a lesser tubercle. In between the tubercles, we have something called the intertubercular sulcus. Now, the word sulcus I would hold on to because you're going to hear that again. A sulcus is a groove. So it would be a depression. We also see on the humerus what's called the deltoid tuberosity. That will be an attachment point for our deltoid muscle of our shoulder cap. Also on the anterior part, just some for identifying markers and language, we have something called the coronoid fossa, a radial fossa, a lateral and medial epicondyle. And then we have from the anterior view at the most distal portion of the humerus, which will constitute that elbow joint, something called the capitulum, which will be on the lateral aspect of the humerus at that distal end, and then a projection called the trochlea, which will be more medial. If we look at it from the posterior view, just some things we want to look at. We have something called the anatomical neck, and then we have a surgical neck. So the anatomical neck is a slightly indented line that mostly circles the humeral head. The surgical neck is just below the tubercles, and it's because it's the most frequently fractured portion of the humerus. Let me mention one more thing on that humerus because we'll see it again. Two more things. Okay, so from the posterior view again, we see something called a radial groove. It's a groove or a depression. It's like in a house vessels and or nerves. From, again, this posterior view at the most distal portion of the bone, we see something called the olecranon fossa. That's a word I want you to hold on to. Okay, when we get to the radius and ulna, these are the bones of your forearm. They have an interesting dynamic on how they work, I think. So from that anterior view, okay, your radius is the side, you're standing in anatomical position. By the way, when you're trying to figure out where these bones are on you, use yourself as a reference point. I would, and then you can use the pictures as well. So you anatomical position. This will be important in this. I think this is probably the most important spot to use anatomical position in the identification of radius and ulna and trying to keep that straight in your head. Okay, the radius is on your thumb side. If you stick your thumb up and say it's rad, dude, okay, that's one little weird way you can kind of remember which side of your arm. Again, it has to be in anatomical positions, palms facing forward in order to make it right. Okay, and then your ulna will always be on your pinky side of your arm. So the radius then, if we're looking at it from an anterior view in anatomical position, we are looking at the right arm. Okay, so the head of the radius is this round little thing that kind of looks like a circle when you look at it, and it will articulate with the radial notch of the ulna right up by your elbow. Then you will have the neck of the radius. We're seeing heads and necks on multiple bones, right? The head is the part that will articulate primarily, and then right below that, again, that bridge bone between that and like the shaft of the rest of the long bone. Then we have a marking called a radial tuberosity. So it's going to be a projection that sticks out. It's going to be an attachment point for something. At the very distal portion of the radius, okay, right as it butts up against your carpal bones or your wrist bones, you're going to have something called a styloid process. Now, we saw a styloid process when we were talking about the skull, but this guy has one also, and so does the ulna. When we look, let's go to the posterior view and keep talking about the radius, just so you can kind of see it from the back side. Nothing really new to mention there, okay? On the radius, just the posterior view. Now let's talk about the ulna. Let's go back to anterior view of the ulna. We can see where we have something called the olecranon or the olecranon process. If you recall, that's what I went back to on the humerus, only it wasn't a process, it was a fossa. So the olecranon process of the ulna will articulate with the olecranon fossa of the humerus. And that's primarily where you get your elbow joint. Now, some other identifying markers that you want to see, you're going to have something called a trochlear notch. Okay, on that anterior side, you're going to be able to see that. Also, right next to the radial notch of the ulna where it articulates with the head of the radius, we have this little bump or projection called the coronoid process. Now, we've seen the coracoid process previously. We have something called an ulnar tuberosity. Again, that's going to be a projection where something's going to attach. Now between these guys, okay, we have an inner osseous membrane that will connect them, and you actually do have some muscles in there that are interesting in their function that will partly deliver an ability to rotate those guys, sort of, or pivot them on one another. That's a function of that interosseous membrane and the musculature that's packed in there, plus part of the function of how these guys join up here at this radial notch. Also on the ulna, I mentioned already that it will also have a styloid process. Now, we also will have an ulnar notch, I don't think I mentioned that, of the radius. So at the proximal end of the ulna, we have a radial notch where the radius will articulate. And then on the distal end of the radius, we have a notch where the ulna will articulate. Now, when we get into the wrist and the hands, okay, all of your carpal bones have names. Okay, I'm going to read through them. I wouldn't get too stuck on them. Okay. Depending on what you're looking at, we're looking at the back of a hand. Okay. Looking at the carpal bones. So the carpal bones are your wrist bones. Then you're going to have what's called a metacarpal. They will be your hand bones. Then you will have phalanges. The entirety of your finger, and it has multiple sections, and we'll talk through that in a second, are phalanges. So your carpal bones, they are your pisiform, your triquetrum, your lunate, your scaphoid, your capitate, your trapezium, your trapezoid, and I don't think I mentioned your hamate, but your hamate. Articulated to these carpal bones of your wrist, again, are your metacarpals. Now, how this works is you name the digits, or you name the metacarpals as well as the phalanges in the same manner. So your thumbs are your first metacarpal or digit number 1. And then you count 1, 2, 3, 4, 5. Pinkies are 5. So thumbs are 1s and pinkies are 5s. And this will be relevant if you're trying to figure out maybe, what another healthcare practitioner is talking about as far as location of what, if you're reading a note, you'll be able to understand what finger they were working on, or what finger the complaint is, or that kind of thing. Now, outside of the hand bones or the metacarpals, when we start into the actual finger, okay, Again, the whole thing is called a phalange. So let's look at them. Digits 2, 3, 4, and 5 all have 3 parts to them. Okay, they will have a proximal, middle, and distal phalanx. Proximal being the part of the phalange that will articulate with the metacarpal. The middle or intermediate phalanx, and then distal will be the farthest one out, the fingertips. Okay, your fingertips of your pointer finger through your pinky finger. The thumb is missing the middle phalanx, only has proximal and distal. Now, when we get to the foot, it's going to be the same pattern, only instead of carpals, it's tarsals. And I'll read through the tarsal bones because I don't think they're challenging to understand, but I will just read them again. I wouldn't get too hung up on that though. Okay, so now let's walk through the pelvic girdle. Okay, I think this is, these bones are kind of neat, kind of cool. Okay, you actually have 2 coxa bones making up each side of your pelvis. They articulate in the back on the sacrum, again at that sacroiliac joint, but also at the pubic symphysis and on the anterior aspect of the bone. So when we're walking through the parts of a pelvic girdle, or we'll just say pelvic girdle, okay? Again, pubic symphysis, anterior conjunction point of the 2 sides of the pelvic girdle. We notice the sacrum. Sacrum is joined to the pelvis on each side at the sacroiliac joint. It is called that because it's joining the sacrum with a portion of the coxal bone called the ilium, the top portion. It's where, if you're a mom, you're resting your baby on your hip, you're holding them on. We call that the hip. That's not the true hip. Okay, the true hip is where the femur joins the pelvis, but we call it this. This is actually that bone we rest our babies on our hips. That's called the iliac crest. Your butt bone, okay, is called your ischium, or that is your ischial bone. The pubic bone, the most anterior portion, again joined or joining the 2 hemispheres or hemipelvises. That's the pubic bone in the anterior portion joined by the pubic symphysis. This here, which we're going to see it a little bit better in a minute, if you're looking at this top picture, where the head of the femur articulates here into the pelvis, this is called the acetabulum. There are holes in each side of the pelvis that will house nerves and vasculature. These are called the obturator foramen. Now, the lateral view will deliver us a way better visible image. Okay, so when we're looking at this lateral view, we can tell what the back side of the pelvis is, the part that's near your buttocks, or the anterior part that's near makes up your pubic region or your pubic symphysis. Okay, so this here, if we're looking at this picture, this lateral view, there's this larger notch in the ilium, which is one bone of this hemipelvis. This is called the greater sciatic notch. The sciatic nerve will run through that. We also have a few other markings. I'm going to go through them. Here's our iliac crest. This is where we hold our babies on our ilium bone. This entire section is called the ala of the ilium. We have something here called the posterior superior iliac spine, or the PSIS. This guy here is responsible for the dimples on someone's back. Like if you're looking at the bottom of their back and you see like the 2 dimples, okay, that's the PSIS marking. If you have a superior iliac spine, you likely have an inferior one. So that's directly below it and right above that sciatic notch. Then we have this blue section of bone, this is the ischium or the ischial bone. Again, this is your butt bone. Specifically, there's something called the ischial tuberosity. So, when you have one of your children, or if you have someone sit on your lap and you're like, oh my gosh, there's a bone in my leg. Okay, that's what you're feeling. You're feeling their ischial tuberosity in your quadricep muscle. Now, the yellow bone here, this is the pubic bone. Again, joining the hemipelvises at the pubic symphysis. Now, interestingly, all of these three major bones of the pelvis, which will be the ilium, the ischium, and the pubic bone, they will help formulate the socket joint of the true hip, called the acetabulum. So this whole space here is the acetabulum. Okay, when we talk male and female pelvic characteristics, I think this is relevant. Okay, we understand once again, there's a difference in this due to the ability of the female to house, make, and carry a baby, and then to be able to deliver it. So the female pelvis has to be wider and broader, and the pelvic outlet has to be wider as well. So when we're looking here, okay, if you compare left to right, male to female pelvis, some identifying markers, okay, the inlet of the true pelvis, which is, if you were looking down into your pelvic bowl, this is what you would be meant. This is the measurement of that opening. So the female will have a wider one of those, but also a wider pubic arch, again, in order to be able to deliver the baby. Okay, we already walked through parts of the femur, so I'm not going to go through that again. Yeah, I don't need to go through that again. Only thing is the patellar bone. Again, that's a sesamoid bone that kind of goes right into the tendon of the quadricep muscle. Okay, but that femur will articulate with our lower portion of our leg. We have two bones in the lower portion of our leg. They are called the tibia and the fibula. The fibula is to be a non-weight bearing part of the leg. Okay. So tibial markings, it will have where it articulates with the femur to make your knee is the proximal portion that we're looking at on the anterior picture here or the anterior view. We're going to have a few markings that we want to look at. We have a medial and lateral condyle, and in between or right in the center of this articular surface of the tibia is what is called the intercondylar eminence. It's going to stick up a little bit. On the anterior portion of the tibia, we have something called the tibial tuberosity. Also, your shin bone is called the anterior crest of the tibia. And then another important identifying characteristic of the tibia is your inside ankle bone. That's called the medial malleolus. Now, when we look at the fibula, again, a lot smaller a bone. Again, this is an instance where they're joined by that interosseous membrane. Proximally, the fibula will join with the tibia at the proximal tibiofibular joint. The head of the fibula has a portion we call the apex, which will again join to that tibia. At the very distal end of the fibula, this is going to be your outside ankle bone, or what we call the lateral malleolus. Now, these two joints at the distal end will join at the distal tibiofibular joint. Okay, when we get into ankle and foot, again, I have mentioned in the wrist and hand, those are carpals, metacarpals, and phalanges. In the foot, they are tarsals, or your ankle bones, metatarsals, or your foot bones, and they also have phalanges. Now, the phalanges of the feet, just like the phalanges of the hands, are numbered the same way. So your big toe is digit 1 or phalanges 1 or phalanx 1, and your pinky toe is phalanx 5. Okay, just like in the hand, the digits 2 through 5 have 3 parts: proximal, middle or intermediate, and distal phalanx or phalanges. Your big toe only has 2. It has a proximal phalanges and a distal phalanges. Metatarsals, again, are your feet bones. They will be that interconnecting bone between your toe and your ankle. Now, the bones of the ankle, you have 3 that will articulate with your metatarsals. They are the cuneiforms. The medial cuneiform is on the inner side of your foot, medial aspect of your foot. Then you'll have an intermediate cuneiform and then a lateral cuneiform. On the lateral side of the lateral cuneiform bone, you have the bone called the cuboid, and that's on that outside edge of your foot. You have a bone that is proximal or more proximal to the cuneiforms. That's called your navicular bone. Your navicular bone will sit distal to the talus. The talus bone is the bone of your ankle that will articulate with your tibia, okay? And your heel bone, one of the strongest bones in your body, is called the calcaneus. A bony marking of the calcaneus is something called the tuberosity of the calcaneus. When we're talking arches of the foot, we say, you know, I feel like we say that the foot only has one arch, but it's actually comprised of multiple arches. We have something called a lateral longitudinal arch, which is on the lateral aspect of the foot. You have a transverse arch, which kind of crosses over the cuneiforms. And then you have the medial longitudinal arch, which will run from your big toe pretty much back to your heel. As we get into joints, okay, we have multiple joint structures that we have to talk through. There are different classifications of joints. There are 3 main categories with regards to function, and that's how we classify joints, according to structure and according to function. So when we're talking about function of joints, either they're immovable, slightly movable, or freely movable. Now, doing it this way is a little bit cumbersome, I feel. So you'll be less likely to classify a joint according to its mobility, just because it may be a little bit difficult to interpret beyond memorization, but also it may change as a person ages. So we'll walk through them. Okay, so a synarthrosis. A synarthrosis is a fibrous joint that can absorb shock, but doesn't permit a ton of motion. And this would be a suture or something called a syndesmosis. So a suture joint, remember we talked about that in the skull. Okay, but as we age, those become completely immovable and fused, and a different sort of classification of joint at that point. Still immovable, I guess, but syndesmoses, this means held by hands. These are joints which are dense with a fibrous tissue that will bind them together. And they do have a limited movement. And this would be an example of like that tibiofibular joint at the very distal portion. So it moves, but not super great. Now, an amphiarthrosis, these are joints that are permitted to move a little bit. Okay, within this category, we have a synchondrosis and a symphysis. So a synchondrosis means held by cartilage. Again, this is a great exercise for you to practice your word breaking apart so that you can kind of understand what it means. Examples of a synchondrosis. This would be your sternocostal joints and cartilage as well as the epiphyseal plate. When we get into a symphysis joint, this is a joint in which there are thin plates of hyaline cartilage that will separate a disc or separated by a disc of fibrocartilage. This is your IVDs or intervertebral discs, as well as your pubic symphysis. Then we have something called a diarthrosis. These are your synovial joints, and this is the bigger category of joints within your body. They have a few features that are interesting. They will be surrounded by what's called an articular capsule. They will have within them synovial fluid to help reduce friction, to deliver nutrient to the tissue on the inside. And there are actually 6 types of this type of joint. Those include gliding joints, hinge joints, pivot joints, condylar joints, saddle joints, and ball and socket joints. So this is a big class of joints. Gliding joints hold on, I just wanted to see where we were there. Okay, so gliding joints, they do just that. They move by gliding, okay? That's an example would be our carpal bones. Again, carpals are the wrist bones. If we're talking about a pivot joint, I mentioned this. This would be an example of that radio-ulnar joint at its proximal junction at your elbow, okay, where we get a little bit of rotation in that plane of movement. Saddle joints are cool. Okay, this is the reason you have an opposing thumb. This is the joint between your carpal bone and your thumb bone. A hinge joint, an example would be the humero-ulnar joint. This is the articulation of your elbow. Your humerus and your ulna make a hinge, okay? A condylar joint. This would be an example of your fingers, your phalanges connected to your hand. So the planes of movement and the directions it can go may be various directions and ways it can go. A ball and socket joint in the diarthrosis category is going to deliver us the highest range of motion, and that is your shoulder and that is your hip. And I've mentioned them twice. So there's that. Okay, so when we're talking these synovial joints and the tissue that's included, I mentioned they have an articular capsule. They're also going to have synovial fluid within it, which serves a purpose, but also some other things you're going to see within these joints. You're going to see what's called a bursa. A bursa is a small capsule or sac in order to help cushion the structures in the joint. It's lined with synovial membranes and filled with the synovial fluid. Now, if you have a tendon sheath, this is going to be a double layered synovial structure. It will surround the tendons that are subject to friction. Okay, so I think this is relevant to understand. I've already mentioned that tendons connect muscles to bones and ligaments connect bones to bones. But when we're talking joints and other articular tissues, we have articular cartilage. Articular fibrocartilage will help distribute forces and help absorb shock. Now, this can be a disc or a partial disc, which is the name for, or which is called a meniscus. We've heard of meniscal tears likely, and you have a meniscus or menisci within your knees. Okay, as we're talking injuries, Okay, we have to recognize, and I think this is, recognizable as we're talking about bones and the injuries to bones. We mentioned osteoporosis, osteopenia, when we have a weakening of the structure of the bone. Okay, and let's go there first since I'm already talking about it. Okay, usually, again, it happens in elderly, early onset in women. So that tells us we have a hormone contribution, which we've already mentioned some hormone factors contributing to bone building and reabsorption, but estrogen plays a role. You can get what's called a compression fracture with osteoporosis due to the lack of or the loss of, the structure of the bone, the actual bone, the mineral matrix. And it's an insidious fracture. Okay, it just gets crushed by weight. And it can cause a lot of pain, but there's really no treatment for it, or they may have treatments, but they're not opted for generally, and they will heal. Okay, osteopenia, I mentioned that multiple times. This is characterized by reduced bone mass, but without the presence of a fracture. We look at osteopenia as the first step into osteoporosis. So type 1 osteoporosis, also known as postmenopausal osteoporosis. This affects about 50% of women after age 50. Then type 2 osteoporosis, this is age associated, affects most women and men over the age of 70. Common areas for this to occur are radius, ulna, femoral, neck, and spine, and all are common sites for fracture. I'm just going to move on to that female athlete triad. So the female athlete triad, this is a condition that involves a combination of disordered eating. Okay. It can be anorexia or bulimia, which is going to lead to amenorrhea, no periods, no menstrual cycle. And this will, if it gets chronic, it's going to lead to situations of osteoporosis. So this is really a female who's already predisposed to bone loss that puts themselves in high risk category. Okay, let me back the train up here a little bit. Okay, we'll talk about fractures real quick. Okay, fractures, as we know, crack in the bone. Bone does heal relatively well in comparison to connective tissue. If you think a lot about what I said about those IVDs, your intervertebral discs, they don't have any blood flow. So they're really hard to heal because you have to get nutrients to the tissue in order to do the healing, take in nutrients for repair, take out, waste material. Within the tissue of a bone, it is highly vascularized. So it has the opportunity to honestly heal pretty well and pretty quickly. The nature of a fracture will depend on the size, direction, and duration of the injurious force, as well as the health and maturity of the bone. Fractures are classified as simple when the bone ends remain within the surrounding soft tissue, and it's called a compound fracture when one or both ends poke through the skin. When the bone is splintered, the fracture is said to be what we call comminuted. So I mentioned compression fractures in regards to the osteoporotic situation. Again, that's just a compression force, like it can't hold the weight, so it just crushes it. Avulsion fractures, these are caused when a tendon or ligament will pull away from its attachment. This could be from, really fast jumping movements. A green stick fracture or incomplete fractures are more common in children than adults. A green stick fracture is caused when a bone bends or twists, but doesn't really break all the way. A stress fracture, these are tiny painful cracks that result from overuse. for some kind of odd force applied to the bone. When we look at epiphyseal injuries, these are related to acute and overuse relate injuries, where we have that growth plate, that epiphyseal plate that gets damaged. So if we do that, we're really going to impair, not only the growth plate itself and the way that it heals, but the ability for the bone to grow in an appropriate way can be a potential risk there. An apophysis, okay, does it say that on? It does. Injuries to this epiphyseal plate can have an impact again on the cartilage and the apophysis. The apophysis is the site at which a tendon will attach to the bone. So both acute and overuse related injuries can damage the growth plate. There's something called osteochondrosis, also known as Osgood-Schlatters disease. This is another form of a bone injury. This happens a lot in young males more frequently, okay? And it's at the knee, okay, where the patellar tendon attaches to the tibia. It's when the quadriceps muscle group on the front of the thigh attaches to the tibia, and it pulls that, it like rips the bone away, kind of. It rips away that periosteum a little bit. So osteochondrosis is common in adults, or I'm sorry, adolescents who play soccer, basketball, volleyball, anything where there's like a lot of jumping. And again, any like hardcore sudden use of that quadricep muscle group. Okay, when we talk about sprains and strains, this is relevant. Okay, first of all, a sprain, that's ligamentous or tendinous. This is connective tissue stuff. When we say strain, that's talking about a muscle. I think we know what dislocations are. We have a bone that's displaced in a joint. If we have a bursitis, this is an inflammation in one or more of the bursa, which is the fluid-filled sac in a synovial joint potentially, where there's an overuse or an inflammation of that bursa itself. Arthritis. This is when the joint's inflamed, and there are different types. Okay, rheumatoid arthritis is an autoimmune disorder. You can differentiate between rheumatoid and osteoarthritis, and that rheumatoid arthritis, one of the diagnostic factors that's happening on both sides. Okay, it won't just happen on one side, and you'll see it in more than one place. It will kind of, float around a little bit. It will create pain, stiffness, swelling, probably turn red. Osteoarthritis is a degenerative type of arthritis from those articular cartilages, that get broken down and really turned into bone. Okay, so I'm going to post another little extra assignment. It is going to be put into the quiz category. I figured doing these little, we'll call them in-class quizzes, really, may help your quiz grades a little bit. So, and it'll be based on the questions at the end of these PowerPoints. Okay, guys. Have a great day, and we'll talk next week in our next recording.